So I'm very pleased to introduce our next speaker, Dr. Voraporn CHAIKITMONKOL, and her talk is entitled Challenges of Polypoidal Choroidal Vasculopathy. Please, Dr. Voraporn.
Thank you. PCV is currently considered as a variant of type 1 macular neovascularization, and it is introduced by Professor Janussi since 1982. And now it has been almost 40 years that we know much better about PCV through the increasing number of research. To diagnose PCV, as Professor Sadda mentioned earlier, ICGA remains the gold standard to diagnose PCV. And we have the standardized criteria, the Everest criteria, to guide us how to do the diagnosis. But if ICGA is not available in your clinic, now we have several non-ICGA diagnostic criteria to identify PCV with relatively high accuracy. So I think challenges in managing PCV right now is not about diagnosis because we can diagnose even without ICGA. But we still found some challenges to select the best first-line treatment for some individual patients, and also what should be the best long-term management for PCV, which we know that have high recurrences. For treatments of symptomatic macular PCV, I think it depends on the patient's clinical presentation. If the patient presents with breakthrough vitreous hemorrhage, you can give anti-VEGF injections and may end up with vitrectomy. If your patient presents with massive subretinal hemorrhage, you can give anti-VEGF injection, perhaps perform pneumatic displacement. Some surgeons might consider vitrectomy with subretinal TPA injection, but this option is still controversial. If your patient presents with leakage with minimal hemorrhage, we have several options proven in large RCT, including combination treatment between anti-VEGF and PDT, and several options of anti-VEGF monotherapy. According to the recent global shortage of PDT, I think the trend right now moves towards anti-VEGF monotherapy. And especially after COVID-19 pandemic, I think we would like to decrease the burden in clinic. So now most of us apply treat and extend for PCV. And currently, we have the recent APVRS consensus and guideline, first authored by Professor Paisan, our chair today. And this guideline suggests that we can consider anti-VEGF monotherapy in PCV, especially for those who present with small lesion, less than 1 disc diameter with good vision. And we can reserve a combination therapy for those patients who are not able to have regular long-term follow-up. Now let's take a look at some case examples that we use anti-VEGF monotherapy in PCV. This patient presents with massive subretinal hemorrhage and confirmed on OCT and ICGA to have PCV. In this case, we are fortunate to be able to start with a aflibercept injection. Following 3 doses of monthly loading doses, you can see the complete disappearance of PED, likely reach complete polypoidal regression. We follow this patient every month for 1 year and no recurrences. So she got only 3 injections and it remains inactive. This patient is an example of a very good response to anti-VEGF monotherapy. But unfortunately, not every patient in your clinic will have good response like this. Let's move to the next one. This patient presented with giant hemorrhagic PED in the left eye. OCT across the lesion, you can see subretinal fluid and huge sharply peaked PED. In this patient, you can see the thin choroid, and I think everyone agrees that for patients with thin choroid, we would not prefer combination treatment with PDT because they will have higher risk for RPE atrophy and later vision decline. In this patient, we start with bevacizumab injection, and by the end of year 1, she received monthly injections of bevacizumab for 12 doses with persistent subretinal fluid and persistent giant PED. What should be the next management for patients with poor response to anti-VEGF monotherapy? We can consider add rescue PDT or switch to another anti-VEGF agent. And in this case, we switched to brolucizumab, and she had significant improvement after the first 3 loading injections. So this is another example that if you found patients with poor response to one anti-VEGF molecule, you can switch to another molecule and the patient can show improvement of clinical outcomes. Now move to case number 3. This patient had PCV, and on ICGA you can see cluster polypoidal lesion. So we know that this case is one of the most difficult features to treat. This patient starts with aflibercept every month for 1 year, but you still see persistent subretinal fluid and the growth of hemorrhagic PED. But we have no other options, so we continue monthly aflibercept for another year. But you can see the enlargement of hemorrhagic PED. By the end of year 2, we have new anti-VEGF agent at that time, faricimab. So we give faricimab monthly for 7 doses, but still enlargement of hemorrhagic PED and the disease still active. You can see subretinal fluid. What should we do now? Very lucky that PDT has become available again in Thailand end of last year. So we apply PDT in this case and the patient showed significant improvement. We can control the disease. The vision improved to 20/40 and we can extend the follow-up period to 16 weeks. So this case showed that in the very difficult case, even after extensive injections with expensive anti-VEGF like aflibercept and faricimab, sometimes rescue PDT still play a role in this difficult patient. Talking about treatment goals for PCV, in addition to visual acuity outcome and fluid resolution, the very important parameter is complete polypoidal regression. Why? Because several studies have shown that it correlates to the risk of recurrences. Here's the study from Korea and follow-up PCV patients for 11 years. They found that after treatment, those eyes who have persistent polypoidal regression or incomplete regression will have higher long-term risk of massive subretinal hemorrhage. And also our study from Thailand, we found the risk for recurrences in PCV eyes receiving aflibercept, including the findings on post-treatment ICGA, incomplete polypoidal regression, and also the findings on post-treatment OCT, persistent PED with internal heterogeneous reflectivity. And these features on OCT, we have previously published that actually it is the features of incomplete polypoidal regression correlate to the findings on ICGA. So if you found these high-risk features for recurrence, keep in mind that don't stop injection right after it achieve your treatment goal, but you better closely monitor these eyes because of higher risk for recurrences. Talking about the rate of complete polypoidal regression, because now we know that we want to achieve complete regression to achieve lesser risk for recurrences. This meta-analysis showing that for eyes that receive PDT, either monotherapy or combination, will reach around 80% of complete regression. What about anti-VEGF monotherapy? You reach only 42%. What about the new anti-VEGF agents that we have? It increased a little bit, but the maximum is just 51%. So what should we do? We cannot achieve highest complete polypoidal regression with monotherapy. So the new treatment goal for anti-VEGF monotherapy in PCV is to achieve inactive polypoidal lesion. What is inactive polypoidal lesion? So on OCT, you can see incomplete polypoidal regression without fluid. That is inactive polypoidal lesion that you would like to achieve after treatment. But remember that inactive polypoidal lesion still have risk for recurrences. So you should not stop treatment right away. You better give injections and extend the injection interval slowly to decrease the risk of recurrences. So in conclusion, challenges to manage PCV in 2025 is to select the best first-line treatment in some patients, and also how to manage difficult cases after anti-VEGF monotherapy. And PCV have higher risk for recurrences, so we should monitor them in the long run. Patient education is really crucial for PCV to help them better understand the chronicity of the disease and the importance of long-term follow-up. Thank you very much.
Voraporn, this is really a fantastic presentation. I have one quick question for you. You highlighted the importance of achieving total polyp closure for the best outcomes for patients. What have you found at baseline to predict who is going to be able to get total polyp closure? You talked about, obviously, after you start with, whether it's anti-VEGF monotherapy or a bispecific, to look for regression. But at baseline, can you tell who is going to have regression or not?
Yeah, that's a very important question. So actually, we have done another study to explore the risk factor, like which one can achieve complete regression. And very straightforward. Those who have higher number of polypoidal lesions, like more than 5 polypoidal lesions at baseline, will have lesser opportunity to achieve complete regression. And also the diameter of biggest polyp at baseline also contribute to who can achieve complete regression. Thank you.